So our next panel is going to be taking a slightly different, more horizontal approach. So the previous panel was a vertical approach. This is a horizontal approach, which means that we're going to have each panelist address the same topic sequentially, and then we'll go from topic to topic. So I'm going to introduce all three presenters at the same time. First, Dr. Rim Cothren, sitting in the middle, is Executive Director of the California Association of Health Information Exchanges, where he leads a diverse group of stakeholders in California through outreach, education, and the development of consensus policies and technologies that promote health information sharing. Excuse me. He's guided the development of a statewide interoperable California provider directory since 2012 and consults for ONC to help design, create, pilot, test, and implement a strategy for nationwide provider directories. He has over 20 years of experience in health technology, over 15 years in systems integration, and over 10 years in health information sharing. Dr. Cothren holds a PhD in medical engineering from Harvard MIT Health Sciences and Technology program. He currently teaches health informatics as part of the University of California Davis Extension program. Next is Eric Heflin. Eric's a 30-year-plus veteran of the software industry, where he's served as an entrepreneur, software engineer, architect, and in various managerial roles. He's the current CTO of the Texas statewide HIE for the Texas Health Services Authority and the CTO-CIO of the Sequoia project, which operates the eHealth Exchange, Carequality, and the RSNA Image Share Validation Program. He's active in several standards bodies and was recently reappointed to the ONC Federal Advisory Committee Interoperability Standards Advisory Task Force. He's currently leading the HPD USA National Extension Work Group and participating in the HL7 Argonaut Fire Provider Directory Work Group. And to fill out the panel, Carl Leitner. Carl is the Associate Director of Digital Health for IntraHealth International, a nonprofit working in low and middle income countries. It supports ministries of health, the WHO, and other organizations such as USAID and CDC to better manage and understand the health workforce through the use of open source health workforce information systems and provider directories. Carl is an active member of the IHE community and has co-authored the Care Services Discovery and Mobile Alert Communication Management Profiles. Please welcome Dr. Rim Cothren, Eric Heflin, and Carl Leitner. So, gentlemen, I'd like to start by asking, and we can go in whatever order you like, what is driving the development of a provider directory in your organization or your environment? And if you could touch on business needs that you're trying to address, the stakeholders, and their information needs.
Well, good afternoon, everybody. And my name is Eric, and thank you for having us. And it's an honor to be here, hopefully to shed some light on some activities going on that might be helpful to your organizations. So I wear a couple hats, standards hat, as well as involved with the Texas HIE and also some national efforts under Sequoia. So I have different perspectives. On the standard side, I actually want to start off my comments with kind of a little bit of a challenge to you all. I was actually at an ONC Provider Directory Conference that RIM helped organize a few weeks ago. And one state got up there and said, you know, we looked at this IHE HPD standard and it wasn't good enough, so we wrote our own. we modified, you know, it's not compatible, but you know, we've got a solution for ourselves. And another organization said something kind of similar to that. And the problem with that approach is that I'm actually one of the co-authors of HPD. I'm not really vested in it. It's just a standard. You know, it's nothing more, nothing less. But what kind of concerns me, though, is that that state was part of the problem. Because they had a problem, the standard did not solve the issue, and yet they were silent about it. And I know they're silent because if they had presented a problem statement to the IHE, that would have gone to my committee. And we received no such problem statement. So I actually want to start off with a challenge to all of you. Please, whatever you take away from this discussion, this meeting today, please get involved and make sure that if the standards that we're about to talk to don't meet your needs, let us know. You know, we're trying to solve these problems for you. I mean, those of us that, like Carl and I, are skipping IHE meetings right now to be here today, you know, we're actually involved with that because we're passionate believers in trying to solve these standards. So that's my standards hat on. From my HI Texas perspective, our needs are pretty simple. We actually have some use cases. In Texas, even though I'm a technologist, I really painfully admit that this all should be driven by clinical needs and by business needs, not by technology needs. And so everything we do starts off with business drivers and with use cases and clinical drivers, not technology. So in Texas, we're trying to service basically about 7 needs that provider directories dovetail into. Disaster response with our other coastal states is one big need. Another one is consent management, because a provider directory works really well with automated consent. They can work hand in glove. Another one is finding physicians with a certain specialty for referrals use cases. Another one is to find hospitals with referrals or for certain use cases and specialties as well too. And the final one, this is where Texas and the Health Exchange and Care Quality have overlap, is automation. What we're trying to do with our provider directory in Texas and also in Sequoia project is to make sure that we have a way to take the human phone call out of the equation. So if you're trying to do exchange between 2 HIEs, you don't have to actually pick up the phone and say, what's your certificate? What are your endpoints? What's your credential? What's your technical information? What use cases do you support? What content standards do you support? What test patients do you have available? Instead, what we're trying to do is automate all of that by conveying that information in a curated, high-quality directory of all that and above.
From a California standpoint, I'd say that many of the things that we're really trying to address in provider directories are similar to the things that Eric already talked about in Texas. One of the things that I was in conversations this morning at breakfast, and one of the things that's somewhat embarrassing is that if you actually admit to the fact that, and think about how long you've been working on provider directories here in California, we've had one for a number of years now, and today it gets less use than it did a year ago. And part of the issue that we're dealing with there is that I think to a large extent we approach this from a certain extent from the technology standpoint, and the technology side has bitten us. And yes, I think I knew that, but really getting to understand it's what's driving things moving forward. So we have long said that the purpose of the provider directories in California were to identify individual providers, organizations that they work for, and the means by which to exchange information with them. And I'd say that that's still primarily the use case that we're trying to address. However, the problem is not how you access that information. The problem is the information itself. What information do you need to accomplish those use cases? Where does it come from? How do you access it to a certain extent? How do you curate it? It's the curation of high quality information. It's what's going to make it useful. And what we're discovering is that a constant discussion about the standards associated, the technology associated with provider directories isn't addressing the pain point. That the pain point is how do you deal with high quality information that you can access when you want it within the workflow and make it work for you. So what we're trying to do now moving forward is to understand in a better way what is the workflow associated with accessing provider information, quit making up our own use cases for how that might happen, or our own 10-year vision for how it might be accessed, but how is it accessed today? And how do we address the pain points for getting good quality information in there? And the technology, and then adopt a technology that supports the ways to address that.
So I work internationally, so most of our work is in Central America, Africa, and South Asia. And so there, the questions and the priorities are a little bit different. For example, largely the priorities are more in the public health space rather than the clinical space. The EMR systems are a little bit less mature. They aren't deployed at national scales. And so a lot of the priority questions are sort of reflective of that. So I think from our use cases that we see, there's a lot of issues with just knowing who the health workers are, okay, so, and what their qualifications are. So we'll see where we really began this process was about 10 years ago. We started developing something called IRIS, which is an open source health workforce information system, or a suite of these systems. And we got to the point where we're deployed in around 25 countries representing 1 million health workers, and that's a lot of data. And so now we're saying how, and that data is being used to better manage and deploy health workers. Do you have enough health workers in a facility? Are they the right types? Are they qualified? But now we're saying, how can we start leveraging that data? And when we start leveraging that data, that's where we come into the HIE. So I think for the past 10 years, we've gone from the paper records to electronic records, and now we're going from, now let's have these integrated electronic records. So from the global priority, there's a lot of driving factors to this. One of the big ones that are called the Sustainable Development Goals, which were approved by the UN. And a lot of that, they're looking at, oh, do we have enough health workers to meet the global need? Right now, there's an approximate need of 7 million additional health workers that are not in the global health workforce. And over the next 20 years, they project that that's going to grow to around 13 million if we don't change anything. So just knowing the availability of health workers and their qualifications across many countries and being able to track that drives a lot of the funding that's available to do this and a lot of the global interest. So I think, trying to have common data models, having standards for classification of the health workers across countries, not just within a country, are very important. So you'll see things like WHO's National Health Workforce Accounts, which is trying to consolidate this information at least at an aggregate level. They have a minimum data set for health worker registries so that we can start making these comparisons and we can start tracking them.
So a lot of us are familiar with standards being revised, changed, new standards coming into play, rather than using existing standards when existing standards will be used. So this is a follow-up question for Eric and Rim. What's missing from the NPI? Why can't we just use that?
So from the perspective of Sequoia, the data we're looking for is not really represented in that data set. We're looking for example, for us, a provider is not just a human, it's also an organization. In addition, that provider entity, whether human or organizational, would also need to include relationship information, such as I am privileged to work for this hospital, or this hospital is related to this organization through some other mechanism. So the short answer is that in addition to those data elements, there's also an entire genre or category that's entirely absent, which is for the e-health exchange and for care quality. We need to know not only the human contacts, and actually mostly we're focusing on the electronic contacts, and that's generally absent in directories such as the INPES or similar efforts.
And I wouldn't really disagree with anything that Eric said. I think that's the dilemma that we face here, is that we really are looking at a complex set of relationships between individuals and organizations to really understand the context in which individual providers are operating, which dictates how you contact them when you're looking for real-life patient information. What we're also discovering is that people, step back here for a second, what we're discovering is that calling this animal provider directories is already beginning to be problematic, is that it gets people thinking about a particular thing, that I'm really talking about a phone book for how I contact a bunch of individual docs. And that's not what people are using it for, and it's not what we're expecting to be using it for. That we do need to understand the organizational context of all of those individuals. We need to understand the organizations and what those organizations look like. We need to understand the locations at which both individuals are practicing and where organizations are maintaining. And we need to understand the electronic means to exchange information with them. So it's a much more complex environment. From a standards standpoint, that really means that there are two things that we need to address. One is, what is the data that we need to represent, and how do we represent that efficiently? And a lot of people have said that what we learned through HPD is useful to us and may give us a lot of information about what data model we should be making use of. And the other is, how do we access that information? And that has, in my mind, been the downfall of HPD, is that nobody supports the API standard associated with it. In fact, a number of organizations did last year and don't anymore. So how do you extract that information, and how is it made usable to the user is an important part of the standard. And now we're all looking towards FHIR as a possible answer to that, when FHIR does not yet support the attributes that we're expecting in provider directories. So there is still a lot of work on the API side that still needs to be done.
So following up on that, in terms of, it's just a phone book, right? So how hard can it be? Tell us a little bit about the technical and process challenges that are impeding either completion, development, or use.
And that really is one of the big issues here. Eric already touched on, a vetted, high-quality repository of information. It seems like it should be simple to get a bunch of information on the physicians that are already part of your network or part of your organization. And the truth is it isn't. People are moving around. People don't see updating their fax number as a high priority in the care of patients, despite the fact that many of us are using that information in order to disclose PHI. So it is, the quality of information is a really big deal here, and dealing with that from a workflow standpoint is a really big deal. One of the things that we're finding here in California is that's probably really the pain point. The pain point isn't how do I access that directory and what API do I use, or if I'm not going to use an API, I will never be invited to come to this conference ever again. But one of the things that people are actually saying to me out loud is that I don't care, give me a flat file in Excel, but I want the data in it to be right, and I'm tired of spending time vetting the data that I get from you. And that's what the issue is how do you make sure that that information is correct and fully describes the professionals that you've got represented. And I wish I had the answer, and if anybody does have the answer, I will be in the back of the room at the end of the talk.
So in the context, first I want to back up the MPI question. So I think from from the context where we work, it's not just the clinical care provider that we want in the health worker registry. It's we adopt the WHO definition of a health worker as anybody that's engaged in the providing of care. So that includes, yes, the clinical providers, but it also includes the intake person, the janitor, the person that's driving the ambulance, the minister of health. These are all people whose full-time job it is to provide care for the community. And it's not just this is just a fuzzy thing that we like to call. It's very important. We looked in Malawi. They have only 4 mechanics for the entire country for the ambulances, right? So unless they had done an analysis and looked at, okay, this is a care provider, their ambulance system there is not functioning. Something breaks down, you have to send somebody out, it could be a day or two just to send them out and come back. That's non-functional. So I think from our perspective, we really need to expand that definition of a health worker. Where we work, there's less private sector involvement in terms of the health delivery networks. It's usually the Ministry of Health or perhaps a large faith-based organization. So between those two, that's providing around 90 to 95% of health services. So there, who is the authority for the data is a lot clearer, right? So the Ministry of Health will know where that health worker is deployed, or they should, right? There is nobody else that would have that authority. There's also large professional bodies, so a nursing council or medical council that is in charge of license, certification, and registration. So knowing that that health worker is qualified, you know where to go, and it applies nationally. So in a lot of cases, the governance of where is the authority for the data is easier in the countries that we work in, because those are already established by legislation or other non-technical means.
So coming back to the data quality issue, the most recent information that I saw on the NPI is that at least 50% of the records have at least one error in them. Do you guys want to comment a little bit more on data quality and how you're addressing that challenge?
So I actually was talking to the gentleman who's, I think Alan Vickers, who actually was involved with the very first version of the of INPES, and he confirmed, it's on the order of magnitude of about a third, at least, is incorrect to some extent. So data quality is actually something we're trying to address in Texas very explicitly through architecture, where the data quality drove the design. And a lot of times people look at federation in HPD or in FHIR and say that's a technical feature, and I want to assert really it's not. It's actually a business feature, because the reason that we have specified that this statewide solution for our directory in Texas is going to be federated is data quality. We actually have a very strong medical association in Texas, TMA, Texas Medical Association, and they have a directory that's well curated and so good that they provide that directory to 13 other states. The other states outsource the directory functions to the TMA, and it's directly associated with the board licensing of that physician. And so how we think data quality can best be achieved is actually pushing the responsibility down to those closest to, in this case, the physicians, and also to those organizations that already have a natural feedback loop to keep that data of high quality.
So I think from our perspective, we have sort of two parts of it. One is it's less an issue of data quality, but more of a data availability. I mean, that if the data's not there at all, then there's no sense in assessing its quality. You know, it's got 100%. If there's zero data, right? So part of it is we've been trying to get that data there, so we have things like we can now report to the WHO's National Health Workforce Accounts. We did an analysis of what is the availability of data for different data fields in the minimum data set. And so we've done that analysis, and you know, the availability of data is getting to be relatively good, and so now we're starting to go back and really address the data quality issues. Part of that is where a lot of the health workforce information has been managed has been at a central level or a federal national level, but we're pushing out a lot of the processes to manage that data down to the district level where the decisions about where a health worker is deployed is maintained. So actually engaging the day-to-day business operations of the healthcare delivery network in that management of the data is one of the ways that we're addressing that quality.
I think that thinking about data quality in authoritative sources of information is an important thing to do. And we're here because we believe in health information exchange, and one of our goals here is to break down silos of information. When we talk about provider directories, we're creating a silo of information, and it's really because of the limited use cases that we're interested in. To talk about California for a second here, SB 137 in California penalizes health plans for having inaccurate information in their provider directories. And the stick associated with that is really pretty significant, and it's financial. And therefore, there is a huge motivation for the health plans to have useful and accurate information on the providers that are part of those plans. So why in the world should I go out and reproduce all of that all over again? And I think that one of the things that'll be the secret of us getting better and more high quality information in these directory services is to understand what are the real sources of information, where are people already expending effort to vet that information, and where can we borrow that rather than reinventing the wheel. And a larger set of stakeholders is going to be a big part of that.
So revisiting this from the Sequoia perspective, we've actually been running provider directory now for about 10 years in production. At a national scale. It's a provider directory of our endpoints within the exchange, not of individual physicians. But one lesson learned from that experience has been there has to be a manual quality assurance step. Every entry in every directory goes through a staff member who vets it for reasonableness. And I would say it's rare to find an entry that's not submitted to us correctly. You know, it's very rare to find a perfect entry coming to us, even from organizations that have been doing this for years. They have staff turnover. Somebody doesn't understand the meaning of a field. They think it could mean A or B, so they choose one randomly. So the manual step, unfortunately, I think is a reality to make sure the provider directory is of the highest possible quality. But then on top of that, we also employ some automation. You know, the values in our directory are largely fielded against a controlled value set or vocabulary. We make sure through automation that those values are adhered to the right vocabulary. The other thing we do is we have automated test tools to make sure that the technical endpoints are actually correct. They're reachable, they respond to requests, they seem to be secure as well too as far as basic configuration. So we put some automation in place on top of that to help ensure high quality.
So Rim mentioned SB 137, and one of the reasons for that is that now that we have an exchange for people to buy their own insurance, and they want to know if their doctor is covered by that insurance, if the provider directory that the insurance company provides is wrong, what happens is the patient signs up for insurance and their doctor's not covered. So the timeliness is really an important issue. Along those lines, how do you manage, what's your process for managing either updates to a provider's information or when a provider either is no longer practicing or is deceased or has moved on to something else? How are you managing those updates? Go ahead.
From our perspective, it's really we go back to the source authorities for that data. So it's the responsibility of theirs to of their systems and their business process to make sure that it's up to date. Really, what the health worker registries or provider directories are doing is just integration of that data, and so it's really the governance that's of the source systems that is in the question.
I'd say that the answer to that question today is distributed management of that information. Means that we expect the organizations that in theory are authoritative for the information to manage it and provide that information. Historically, for us, that's been through a federated architecture. Moving forward, it's still probably distributed management. But I think that the important thing as we move forward is identifying the best sources of that information. And it may not in all cases be the HIOs or the enterprises that are participating in our HIE networks, but it may be other sources of information as well. And we need to understand what they are useful for, how to integrate them, and make sure that they're integrated appropriately.
In general, the other thing I would add to that, to all these comments, is that I think the Intermountain and Mayo Geisinger collaboration, the CCC, came up with an innovative solution for patient matching that also can inform provider directories, which is don't just view this as a single group of data about a person in its entirety. View that as individual data elements. And you can actually find some sources that are better than others, all the way down to the discrete data level, such as, for example, you may be able to pull from an authoritative federal or state curated database that's guaranteed to be correct for one field, whereas in the same database, another field may not be guaranteed to be correct. The other thing I'd add, too, is this is not all about data. It's also about policy, about governance. And data quality itself is largely not an issue of the actual raw data. It's human factors such as workforce incentives are also at play. If you have a person that's incentivized to do something quickly and create a duplicate entry as opposed to they're being incentivized to spend another few seconds, do a few searches for some variations on the theme to see whether or not that entry already exists in the directory before creating a duplicate, then that also can dramatically increase data quality. So it's not all about standards or technology. It's also about some human factors considerations as well as policy.
Do you guys want to share any best practices along those lines?
Well, I can maybe not.
That tells you something, doesn't it?
Well, I would say where we're going. I mean, I don't know. It's just yet to say where we are. So one of the things that we're doing. So most of our work is under a larger rubric of something called OpenHIE. OpenHIE is a open source, open standards-based health information exchange that brings together a health worker registry, a client registry, shared health record, et cetera. And so identify standards that we can use. Some of these are IHE standards, some of them are FHIR standards. So one of the things that we're doing is we're working with the FHIR group on an entity matching service, an extension that's going to apply to all of the FHIR resources, whether it's the patient or the provider. And so we will be integrating that with our health worker registry and our client registry. So this would be for identification of duplicates when we enter a new provider in, so that we'll have just a service that can be queried against all of the existing data sources to say, okay, here's a potential duplicate. That's also will be used for one-time for the initial imports. If we're doing a data load from a system that's just coming online, we'll be able to match against that service. And then as well as when we start integrating the various data sources, we will be putting in the matching against the identification of potential duplicates. And so as we go forward and those duplicates are identified, we'll start doing automatic merges based on the reliability of the data and authority of the source systems for that particular data field.
So for the Health Exchange, what we've done to try to address that is we're a believer in trying to have non-perishable work products. We don't want it to be just in my mind or just in someone else's mind as well. We want it to be documented, at least to the extent that the knowledge can be transferred. So what we've done is we published an internal guide that basically deals with data quality and data governance related to the provider directory we maintain. It includes probably 30 or 40 specific kind of in the details best practices. I think I've already summarized quite a few of them already, but the things like does this pass the reasonableness test? Does it actually pass the technical format considerations? Does our tooling detect any errors? Because we actually have codified about 50 rules or so in our tooling to make sure that before an entry goes into our directory, it first has to pass all the codified tests we can, such as value not being blank. Now, obviously, there's limits. It couldn't test necessarily to see whether or not an organization's name is reasonable or not, as opposed to looking like a person's name. But we do have the human review as well to automation to help ensure, catch things like that are really not viable at this time to automate. So it's a combination of published policy, tooling, and human review as well for reasonableness.
There are a couple of things that people are also thinking about incorporating into directory structures that may not be well represented today. One of them that I hear a lot of people talking about is some assessment of the quality of a piece of information. Eric already talked about that. You may be able to get down to the element level to make a decision on what is authoritative, who's authoritative for that piece of information. You can also make assessments sometime on how high quality a piece of information is. When was it last vetted? How was it last vetted? And therefore, what is the certainty that you believe that that's correct? And that may be very useful information for an organization that's looking at making use of it and making a decision. So for instance, if I think that's 90% chance this is the right fax number, then will I use it to send PHI? If I think it's a 20% chance that it's the right fax number, will I call them first and find out? Will that trigger me to look at that information separately? The other piece of information that a lot of people are starting to take a look at is incorporating hysterical seems to be right for provider directories. Historical information about providers. That first of all, some organizations need that. If you're looking at vetting claims or requests for verification of a patient's ability to claim disability, for instance, you need to know information about a provider, when they practiced, where they practiced on a particular date, and incorporating that information in directories will be important basically for some use cases, but may be useful in helping you to understand whether you've got the right provider, et cetera, by incorporating historical information as well.
So I really agree. In fact, one of the things we're working on right now is a FHIR-based provider directory with over Josh and Argonauts and so on. We're actually starting Connectathon, I think, next week to test that out, to see whether or not we've got it right. And one of the things built into that is actually provenance, which is, I think, where was talking about where the data come from. Also version control. How long was this data element in effect and known to be good or reasonably expected to be good at that particular point in time. So the other thing, too, just kind of a human factors issue is I think the Social Security Administration, I don't want to speak for them, but I think they kind of humorously point to one of their real world situations, which is that one of their facilities in, I think it's Beth Israel, Deaconess, has been known by something like 13 different names over its multi-year history because of all the mergers, acquisitions, renaming, and so on. And so originally FHIR actually had a field for an organization name. You had either an option of 0 or 1 values. And so one change we just made a few weeks ago is to change that one field, so now it's 1 or many. So it has to be there, otherwise what's the point of having an organization in the directory unless there's a name with it? And now you can have as many names as you want, and the hope and the intent is that entities, software companies building directories on top of that will display this in such a way that they can use a good search algorithm. So the patient can put in the name, no matter how it made sense to them. Maybe they're treated 10 years ago in a prior name. Well, they can actually perhaps then search for that by having an alias for that organization's name represented in the FHIR data model.
One other comment about data quality. So just to give a quick vignette of the story. So we were working in Liberia before Ebola hit, and we were working there to set up their national HR system. And so there was a data collection process that went out to all the health facilities. This is a very time-intensive and labor-intensive and resource-intensive process. But we did that. We had a good idea of actually who was at the health clinic. And so as we're putting that data into the system, that's right around when Ebola hit. Okay, so at that point, basically none of the health workers started showing up at the clinic because either they were dead or they were fearful. The government was promising to pay them more if they showed up and they weren't getting paid. There were a whole host of issues, and so we really had no idea who was actually in the workforce anymore. But what we were able to do is, since we had that original data, we connected that health workforce database into an SMS platform that lets you do workflows to do data collection. And so one of the first use case that we sent out on that data collection platform was a verification of, is this, I'm trying to reach Carl Leitner. Are you a health worker? Yes. Are you I'm saying that you're working in this facility, yes, no. And so we could ask them a series of questions to validate that they were actually the health worker that they were, and they were showing up to work. And so that sort of routine or semi-routine data collection process with the actual health worker, I think, is an important tool that can be used. And it's relatively low cost, and especially compared to field visits to every health facility.
We're about halfway through, and I'm going to keep asking questions, but if you have questions, step to the microphone, and I will insert your questions in between. So at any time, feel free to step forward. Go ahead, Walter.
Thanks, Walter Szyjanski. Is this on?
It is. You have
Great.
to. If you don't hear yourself speaking, we can't hear you.
Okay. I'm going to go like this. My question has to do with content, getting content. Obviously, that's as big, if not bigger, an issue than some of the technical standards involved. I guess for all of you, particularly though for Rim and Eric, working here in the States where we have lots of very large provider organizations that are members of the Sequoia Project or that are involved even in the California HIE Association and others. These large provider organizations, are they coming up with their own provider content for the provider directories that you all are working on? If not, why not? If they are, is that a good source of content, and is that sufficient to at least get a really good start on a somewhat comprehensive provider directory?
So I'll go ahead and get started. You're asking really good questions, and I wish I had really good answers for you. So the truth of the matter is that, yes, those types of organizations are providing content. To some extent, it's because they need that content to carry on their normal business, to really coordinate care for patients and to interact with each other. And so that is something that they need. Is it easy for them to do? Absolutely not. You would expect that any provider organization has a really good handle on the information about the members of that organization, but the truth is that people move, people change. Large organizations, it's hard to keep track of, and if you've ever tried to maintain any phone directory associated with a corporation, you know how difficult that is. So it's much more difficult than you would expect. Is it a good starting point? Yes, I think it is a good starting point. Doing that in the vacuum of understanding what the data quality and what the issues are associated with it makes it difficult. And one of the issues here is how do you make use of that information, and how do organizations like that consume that information? One of the things that we're finding, and again I get back to the failure of HPD as a standard, was really not the failure of the standard, but the failure of the API to be adopted by vendors. And so that means that exchanging that information through an API just plain doesn't happen today, and that organizations are looking for other ways to exchange that information so that they can load it into their environment and make it and expose it to their users in a way that works into the workflow. And that continues to be an issue that we cannot ignore, and we need to address as we move forward. How about that for a non-answer? Because I feel like that was a real non-answer.
Just to comment on the global perspective, some of the data fields that are important from a global perspective aren't going to be, or I don't think are going to be, they're certainly not in what's in the draft for the FHIR provider directory, are things like the birth country of the health worker, the training school that they went to, either for pre-service education or in-service education, because if they were looking at the global labor market analysis to know how to track these health workers and where they're coming from, are these a bunch of Philippine nurses coming in, and what countries are they going to? That's a very important thing to understand. I don't think that's going to be in the provider, the source systems that from the provider organizations.
So from the Sequoia perspective, we basically go back to the organization, and it's a contractual obligation of theirs to keep the information correct. They don't always follow it still, even though it's actually an enforceable contract provision. So we have to have manual staff review to make sure the data is accurate. Even for our limited directory, which is it's national, it's been in production for 10 years, but it's still limited in terms of scope. From the Texas perspective, we also are going to put in, we've got broken our procurement into multiple phases for our statewide provider directory. It's drafted, it hasn't been released yet because we're held up due to IEPD funding that's associated with and a contract between the Texas Health Service Authority and the Texas Human Services Commission. That has to be in place first before we can move forward. But when we release our RFP, among other things, it's going to be broken into, I think, about 15 different work streams for the provider directory. We didn't make a monolithic procurement of saying this is just one directory. We're asking for a vendor to solve the problem. We've broken up into technology solutions such as hosting, software. We have a data quality work stream. We have content work streams for physicians. We have a content work streams for hospitals and other organizations as well. And we have a quality assurance work stream as well. And I expect there'll probably be contractual obligations, potentially including penalties, assessed if the data quality is found to be below a certain bar.
Well, I guess neither of you answered my question, which was basically, let me put it another way. Have you in your respective provider directory efforts asked the large provider organizations in your jurisdictions, California, or let's just talk about Texas, for their list of providers and some basic contact information, not necessarily
No, we have not.
electronic? And why not?
Our approach is put out a procurement and letting anybody that wants to respond. And our expectation is probably that our Texas Hospital Association and Texas Medical Association will probably respond to that, where they actually are the curator of the provider directory as opposed to hospitals. But nothing prevents a hospital or a large hospital chain from indeed responding. But we're not at that point in the process where we know who's going to respond yet. But that's just my expectations.
So my answer to your question is yes, we have. And the barrier has been a technology one. And that has been the problem, is how do you provide that information and how do we expose it to other providers? We just don't have the capability for that right now. And that is what's driving a revision of directory services in California this year and next.
You know, to editorialize a little bit too, one of the things that I've kind of noticed as a pattern is that we tend to have an abstraction on top of the data. You know, maybe the data we're filling our directories with comes from 2 or 3 levels above the IT person in the trenches that actually is sent the email the day before someone is terminated saying, deprovision this person at this particular point, date and timestamp. Or we have a new staff member, add them to the email system, get them their credentials on this particular date and time. So at some point, each organization will have an authoritative group or individual that actually is going to know exactly who should be accessing their systems. I think we need to go to that level of detail. Let's go to the authoritative sources within organizations, not 3 or 4 levels above that.
One other thing, and then we'll get on to the next question. I think Walter points to a real issue that we need to consider here too. I am trying to revise my thinking. Carl has several times now talked about health workers as opposed to providers. I would say that if you'd ask the 3 of us, none of us call what we're doing provider directories today, and I think that there is a misconception that we put in people's minds when we continue to call things provider directories. Asking a large provider organization for their list of providers is a piece of the puzzle and is an important piece, and we need to get there, and I don't want to discount that at all, but there's a lot of other information that we also need to other individuals, the organizational structure, et cetera, that may not be part of that same ask. And I think that we need to start expanding our view of what the topic is that we're talking about.
Social services, like mental health services.
Absolutely.
My question fits perfectly. Okay. So this has to do with non-clinical providers, with the advent in the U.S. now of trying to integrate social interventions with clinical interventions, like with veteran-directed programs. We're having to deal with getting lots and lots of providers who are never going to have an NPI. They're somebody's mother who's going to come clean their house, their relatives. There are all kinds of people who aren't. It sounds more like the international thing where there's a bunch of associated people who are going to be spending the money that the veteran has to provide care. And I was wondering if anything you're working on in the standards is addressing that, the fact they won't be able to be identified by an NPI. You have to come up with some other suitable key data, that kind of thing.
So the 2 standards I'm really aware of that are potentially considered to be viable in this domain are our fire-based provider directory, which is in flight as we speak, that's evolving on a daily basis and about ready to be piloted. So it's not even new yet. It's not even quite that mature. And then the other one is HPD. Both of those, though, have the concept of not only just an NPI. What they actually have in them is a concept of an assigning authority and an ID. So by breaking it apart, it actually gives us a huge amount of flexibility. For example, the assigning authority could be that person's driver's license, state driver's license bureau. and under that, the driver's license number. It could be a social and the social security number. It could be a military ID and a military ID value and so on. So the standards already can address that by not requiring a specific ID. However, earlier I mentioned that data governance and quality assurance and policy are also pretty big factors, and that's where perhaps policy could come into play. For example, maybe California elects based on its specific state laws that here that value will be maybe a statewide driver's license or its equivalent state-assigned ID, followed by the ID value, if that works for here. So policy perhaps is a part of the solution for that, in my view.
So there's a third standard, care services discovery, that's also from IHE. And that also, first of all, that adopts as a definition a health worker in WHO's definition in terms of the prominence of that or the domain that it's operating in. Second of all, since it's international, there is no NPI that works in Zimbabwe, for example. So we definitely have the notion of that local identifier with the signing authority and the code. So I think from the three main standards that are available, the NPI is not a prominence field. Care services discovery, and there is an open source implementation of it, and it's a fairly comprehensive data model, and it has a representation in FHIR as well. So it's really addressing the multiple data sources and how do we integrate those data sources together. How do we ask a provider organization, give me a list of the data that you have, make a very simple ask, and then we have one actor that will integrate that data and is responsible for sharing it out. So it really separates the concerns of the data integration from multiple directories to making the data available.
Hi, I'm Mark Branding, working with San Diego Health Connect. And you may have already talked about this, but California had a bill, SB 137, regarding health plans. And the health plans are supposed to call the providers, and they're required every few months to give them accurate data. How could we tap into that?
I think that's a really good question, and we talked briefly about it, but let's talk about it a little bit more. One of the things that's going on in California as a result of that bill is that there isn't just one health plan here, and that means that the health plans individually, what you would expect is that the health plans individually are going to start asking their physicians more and more often for their version of the set of questions that they need for their provider directory, and providers are already confused enough about providing that kind of information. So one of the ongoing pilots here in California is a collaboration across the health plans for a single consolidated ask to the physicians, a mechanism for vetting that information and making sure that it is high quality, and to make sure that physicians get asked once for all of the plans. I think that understanding, and SB 137 here in California may be one of the early examples of penalizing health plans for bad information in their directories, but it's not the only one today, and it's not going to be, in the minority soon. It's going to be something that we're going to see, I think, in a lot of places in the country, and I absolutely believe that it's pain points like that and other stakeholders like that that provide some real opportunities for us to increase the quality of information that we're getting, is to make sure that we tap the sources of information that, for whatever reasons, are vetting that information carefully.
There is another way to try to get some pressure put on to get that data accurate. In Uganda, they have a big problem with quack doctors, so people practicing without a license. And what they did is we worked with the medical council to say, okay, set up an SMS service. Anybody can send an SMS with the name of the doctor, and it's going to return whether that person's licensed or not. So at the very beginning, there are a lot of people that weren't licensed. And it could have been just they weren't keeping their license up to date. But after that, after this public service went out that was available to the citizens, that really increased the registration and the accuracy of the information in the medical council, because no doctor wants to say, oh, no, you're not a real doctor, right? Like, that's a really bad thing. So having that citizen-centric information and making that available to the citizens and to use, I think, is also a great point of political pressure.
Hi, Lynette Scott from Healthcare Services, and we do have an online portal. You can go and type it in, and if you're an organization, you can ask for the licensed medical providers. It's all public information. So we do have that here in California. But what I was hoping you could talk about is a standard I haven't heard any of you mention yet is the X12 EDI 274. You can tell I'm the pseudo-techno geek. I had to bring my piece of paper. But that's actually a standard that we're implementing through Medi-Cal with our managed care plans and asking them to transmit the provider networks for their plans on a monthly basis using that standard. And so I was wondering what experience you have with it.
So from our perspective, we mostly have been focusing on clinical data, and correct me if I'm wrong, I believe that's an administrative data standard largely. And so I think really the same issues, though, apply, which is you still have to be able to match a person, that, being a patient, a person being a healthcare provider, an organization, perhaps a plan, and then a relationship between all of those. And I think the standards we've been talking about today can actually assist no matter whether the transport is EDI, or X12 versus HS7 V2, V3, Fire, Direct, or CDA or some other standard as well too. I think those really provider directory is a business function. The standard is just a means to unify and agree upon an approach for deploying that. And so I think really all my comments, and I think probably most of our comments all still apply for the EDI world.
I would agree with that. We don't have any specific experience with the 274 transaction. However, one of the things that will really drive interoperability is a common understanding of the data model and the attributes associated with it, and there are crosswalks between the 274 transaction and HPD as an example, so that you can understand how those fields are mapped into the two separate standards, and therefore how the same information might be transported or might be represented under those two standards. I think it's going to be increasingly important to understand the terminologies that we're using for attributes and what those attributes are meant to represent across the standards if we're going to make interoperability work at all.
One of the things I think is really brilliant too about FHIR is they've actually taken a step of building into the standard mapping. So for example, one of the things that I'm contributing to the Argonaut work group is actually mapping the current evolving HPD FHIR, or the FHIR spec, to the HPD equivalent. And also to the UDDI equivalent, which is an older standard that was also based on e-commerce transactions. That never really took hold, but it's still out there and used by the exchange and a few others as well. So the actual base FHIR standard will have mapping between those elements and the FHIR equivalent whenever we can find an SME that actually is willing to provide that mapping. So that's really useful, because then you can go to an authoritative source saying, at the time we created the spec, here's what we think the mapping could look like between, for example, EDI and say a FHIR-based provider directory.
So one of the reasons for asking is because there is a lot of focus right now. So in California, we have the new law that's been referenced several times. But the other piece is this intersection between the clinical and administrative. And so it's interesting sitting in the Medicaid agency. We do a lot of work on the administrative standards, but we're also starting to work on these clinical standards as well in terms of how to receive and transmit, and thinking of those universally as data services that go by one standard or another. But I bring up that standard around the provider directory also because there were new managed care regulations that came through the Medicaid program. So this is not just a California issue, but nationally. The final managed care regulations came out this spring, and they were huge. And while not as big of a lift in California, a huge lift across the country for many states with their managed care organizations. And one of those requirements is around having up-to-date provider directories. So part of that is working with our managed care plans that are kind of perhaps the traditional, but also long-term care, mental health, dental, et cetera. So it's a standard we'll be using and are implementing as we speak.
So one of the kind of odd things you may have picked up on too is I actually have kind of a foot in both camps. I'm a foot in the HPD camp, where I'm trying to kind of close out the standard this year for the HPD USA National Extension. But I also have a foot in the FHIR camp. And the reason is I really don't care which standard we choose, as long as we choose one and the industry rallies around it. That I really am passionate about. But the good thing, though, is that where we can't just use a single standard, one of my hopes and one of the reasons I have a foot in both camps is I'm trying to make sure the data model is compatible. So that if we have the same basic data model, the same attributes, maybe the same vocabularies, for example, specialties, things like that, or credentials, if we have the same vocabularies for those, then on top of that, we could have, if we need to, a FHIR interface, we can have an EDI 274 interface, we can also have an HPD interface as well, too. So hopefully we'll get to the point where at least there's convergence at the data level. And I'm trying to see that happens, but I can't do it alone. And please help.
And I think one of the distinctions that we ought to be trying to make here is important there is that when we're talking about directories, to a large extent, that really should be talking about the data that's sitting underneath it, and then there are potentially multiple APIs as long as the APIs support the data model. And we ought to be thinking that. What I heard at the ONC workshop that happened several weeks ago was that most people supported the HPD data model, but not the API associated with it, and we are not accustomed to separating the two. And in fact, one of the things that people point out to me on a regular basis is that FHIR doesn't have a provider directory. FHIR is an API. That's all it is, and it tells you how to represent provider concepts through data transmission, but there is no underlying data model per se, merely how it's defined and how it's represented in the API, and that CSD is not a directory but a mechanism to discover services. And I think that we need to start making those distinctions, and 274 transaction is an API to get to directory information, and we need to think that way.
I have a question regarding interoperability and the data standards behind various national efforts. For example, the eHealth Exchange Sequoia project is one mechanism. There's also Commonwealth, Care Equality. How do these interrelate? Will they be using similar standards? And what's the cross-connection between those ultimately? For example, in a disaster use scenario or use case where you may have people moving from an unaffected area, or from an affected area to an unaffected area, and how can that communication occur?
Well, just briefly from the Texas perspective, we hope and view them as all working together. We want to avoid silos at all costs. The Texas Health Service Authority has a legislative mandate to connect all of those entities you mentioned, including every doctor, every patient, every hospital, every practice, every pharmacy, and so on in the state. So I'm hoping there'll be convergence. From the Sequoia perspective, wearing that hat now, and as I imagine, Care Equality, who is under Sequoia, eHealth Exchange is under Sequoia, and Commonwealth may have different answers to some of these questions, but I'll do my best to interpret what I think Jitten and others may say. So eHealth Exchange, simply put, is a network. It has live participants in production, has 100 million plus patients. Over a third of the country today is live with it in production, and has been for many years, including federal agencies, many of those in the audience today, Kaiser, Dignity, and many others as well, too. So the Care Equality is, in my mind, the only entity in existence. It's a nonprofit. It's a 501c3. It's organized for public good. It's not a trade association. And its only mission is to connect other networks together, of which, for example, eHealth Exchange is a network. Commonwealth is, in my mind, also a network. It has a certain defined community, organizations participating in it. And so Care Equality's mission is to try to connect all this together. And unlike, say, a 501c7, like I think Commonwealth is, or Direct Project as well, I think, it's not representing, it's not a trade association representing its members. It's actually, Care Equality and eHealth Exchange are under Sequoia, which is designed just for the public good. We're actually trying not to make money. If we do start making money, we actually reduce our rates. We actually cut our rates in half a few years ago in our testing fees to represent our greater efficiencies. So we're trying to continue to break even because we're organized just to help people. It's just for the public good. As far as the standard side of your question, I think every entity I just mentioned, except Direct Trust, actually uses the eHealth Exchange specs largely. Commonwealth, I believe, and I don't want to speak authoritatively for them or represent them, but my understanding is they use the eHealth Exchange basically 2 out of the 3 specs. Patient discovery they don't use, but they use query for documents, retrieve documents, basically give me a list of patient data files you have available and retrieve those. So I think those are common among Care Equality, eHealth Exchange, and Commonwealth. Commonwealth uses a different mechanism for discovering patients, whether you contribute your patient census in advance to a common location, and then you search from that location. And it's not good or bad, it's a matter of trade-offs. You have probably quicker, more predictable performance as a result of that, but you also have more overhead too. and more privacy concerns, I would assert as well too. So it's just a matter of trade-offs as far as that goes. So I hope I've answered your questions. I'm not sure if anybody else has thoughts too.
Just a little bit more that I would add to that. I think that if you look at a lot of those networks, those organizations, you'll find that what they do in provider directories reflects the needs and requirements of that organization. So Eric talked a little bit already about eHealth Exchange and care quality, and a lot of the information that's represented in the directories there represent the organizations and the endpoints associated with them. If you look at Commonwealth does not have a provider directory, and their architecture doesn't call for one. And therefore, there isn't a concept of a provider directory within that network at all. If you look at, and I'm not a Commonwealth member, so if I've got that wrong, I'm sure that somebody can beat me up in the parking lot afterwards. I'm also not a member of Direct Trust, but the motivation behind provider directories there is to be able to get the direct addresses associated with primarily with individuals, although direct addresses may be assigned to organizations as well. And therefore, it is a listing of direct addresses associated with individuals with some demographic information associated with it that follows a proprietary file format rather than a standard. And it's because that works well for the organizations that are part of that network. So I think, again, if we're looking for something that really points towards interoperability, it's going to be understanding what is the superset of the data models that represents all of our use cases, and then we can start talking about how we interact and what the APIs are associated with that.
And just to add one other thing, and you can correct me if I'm wrong, but I believe that in some cases a direct address will not be a specific provider, but it may be a department or a hospital, and so there needs to be clarity about what the direct address actually refers to.
This actually has a technical implication as well too. We debated on for several weeks on the FIRE project of where should that address exist. A lot of people think intuitively it should be with the physician. Well, what happens if that physician practices at 5 hospitals? All of a sudden that model breaks. And so what we've done instead is we represent that address on the relationship between that person and the organizations. That way a physician, for example, could have multiple addresses, just as kind of a technical side.
Very good. There's been a lot of discussion, I guess, over the last couple of years about HPD, the HPD successor, and now talking about FIRE and so forth. It seemed to me if I were a businessman starting a directory service, what I'd want was a directory service that you could access with whatever tool you were using. So that, and that may be what you have in mind, Eric. You said you were working on a FIRE version as well. Is that something that you anticipate? Is that they'll be able to use either?
Well, that's probably one of the big benefits of FIRE, honestly, and trying to look at this very neutrally, is directories are not that complicated as far as the structure. There's about 10 objects, positions, organizations, locations, addresses, relationships, the type of entity, like the technical endpoint. So there really is not that much compared to certainly to, say, a lab result panel. Mm-hmm. I mean, that's orders of magnitude, many orders of magnitude more complex. So one of the things that my good friend John Murky stated in one of our standards meetings a few months ago was that, part of the frustration with HPD is it's a pretty complex solution for a problem that really is not that big of a problem. And so if you use something like a FIRE-based approach, it's not unreasonable for a fairly mid-level to junior of a software engineer to sit down and 3 hours later walk away with it working. Mm-hmm. I've done it myself, and I'm a rusty programmer. I sat down and I actually coded a FIRE client back about a year ago in 15 minutes, and I haven't had them programmed for a few months before that.
You're hired.
It's really trivial to do a basic client based on FIRE by design. Someone had a quote that if my next door neighbor's kid can't program it in an afternoon, then it's too complex. And I think as healthcare, we're dealing with so much complexity already. Mm-hmm. Whatever we can do to find a simple solution for a relatively simple problem is just going to help kick the ball further down the field. And that's why I really think provider directory based on FIRE is probably going to do. It really provides a simpler solution for essentially the same problem. Whereas HPD, you have to stand up web services, a SOAP client, you have to have a package, a container, a security model, and FIRE, you probably have to have a security model as well too, depending on your deployment. But it's a simpler solution. I think it's a lot easier to code personally.
Okay. Thank you.
So if I answered your question.
Yep.
Good afternoon. I'm Michael Marchant with UC Davis. I've been thinking about this solution or these problems for a long time. I've been in healthcare for 20 years. And sometimes we take a very complex or a very simple thing and make it very complex, and we're trying to connect large organizations with multiple data elements. And I'm wondering, with the change in technology and this, what you just spoke about, it should take 15 minutes to connect something. If we're not looking at this maybe backwards for today, and why wouldn't we have the patient, and then back to the concept of who owns the record, the patient or the provider, but how about the patient own their data? How about for every encounter I have with a healthcare organization, I provide that information to the patient, and as the patient goes provider to provider, they actually have the ability to take that information and share it with the next provider, as opposed to taking the organizations, Sutter, Kaiser, whoever, and trying to have them identify each element and all of those things. If I can just take my record with me as I go, and how many here in here have a Google account or an iTunes account, right? I mean, we've done some good work with the Apple Health Kit with some very small pieces of data elements. I don't have to have an EMR, I just need the information. So any thoughts on changing the paradigm from an organizational-based approach to a patient-based approach on how we do exchange and giving the record to the patient?
Well, I personally would love to see that happen. The most passionate use case I've ever seen was about the Wounded Warrior Project. I'm not sure if you've seen that, where basically this lady who is a wife of a veteran who has suffered a concussion, or actually it was an improvised explosive. And the poor gentleman had essentially 7 specialists he had to see on a weekly basis, psychological, neurological, he had to have ophthalmological, eye care, he had to have dental care, he had to have facial reconstructive surgery, physical therapy. So basically she said, I am the MR. I walk around in the trunk of my car, I have 6 milk crates full of my husband's records that I have to take because I can't depend on them being in any given location, especially given the fact that the VHA is now, and this is, years ago, and where progress has been made, but basically she was, between public and private, she was basically the MR. And so if we do that, I just hope we don't burden people that are not prepared for it, and we make it easy and actually viable for them to accomplish that for those that do want to engage at that level.
So I'll just say I have a direct conflict of interest. That's what we're building. So that will come. It just depends on whether people will use it.
I just think that with everybody having a smartphone and the capabilities of an app, pushing the organizations to connect as opposed to making all the information that's available for the patient to the patient, which isn't available today for any of you who have a MyChart account. You're not seeing your full patient record. You're seeing a subset of that.
Well, and you can thank John and Josh and others who've been working on FHIR and open APIs for making that possible.
Yeah, there are some promising things too in that regard. For example, you've probably heard of Blue Button, which is a mechanism for a patient to download the record and curate it. Another one is right now Sequoia has 2 projects, both the Health Exchange and Care Quality, that both have a PHR profile that's about complete. That will actually give a individual patient or consumer, hopefully a healthy person, not necessarily a patient, access to their record or to an authorized, say, family member's record as their proxy. But there's unique considerations we have to take into account too, for example, security. How do we know that person is not impersonating a VIP, for example, trying to steal their information? That can be handled, but we just need to take into account considerations like that as well too. But there is progress being made, and there's a couple of efforts right there. Plus, all the PHR organizations in the room probably have solutions as well too.
So a couple of things that I would say about that. First of all, one of the issues that we haven't really talked about much today is access to the provider directories. Health plans have had consumer-facing provider directories forever. When we're talking about things here in this room, a lot of the use cases we're talking about, people are looking at making this accessible only to providers. So at some point, we need to address who has access to this information, for what purposes, et cetera. That all said, I think that using consumers as at least part of the picture is an incredibly good idea. I can imagine that, for instance, being able to get my feedback that you've got the wrong phone number for my doc is a really useful piece of information. I think that also relying on me to know the names and addresses of my providers that, one of which I've only seen once ever, is you're going to be in so much trouble. So, but I think that we really need to get to the point where we're leveraging multiple sources and we understand how to leverage them. And I think that overlooking consumers as a potential source of information would be a huge mistake. I think that's going to need to think about that more, but I think it'd be a huge mistake.
One of the cool ideas, too, I really am a fan of that was developed by the CCC, was the idea that patients, or really consumers, are not only advocates in terms, or are allies in terms of healthcare, but also in terms of patient matching. They actually envisioned this idea where a patient could log into the portal to access the records, and have a password strength test. Well, they could have a patient matching quality test. So it could say, for example, we could match you less ambiguously if you gave us your middle initial, or you gave us the last 4 of your social, or that you gave us something else, some other information. And so I think engaging with and treating patients and consumers as our allies in this whole process would be very beneficial in many regards.
With the permission of the moderator, I'd like to make some comments as opposed to ask questions.
Sure.
Thanks. So the use case of the patient or the patient advocate with a cardboard box full of records in the trunk isn't new. I think I first came across it 20 years ago, where a patient was forced by circumstances to change health plan and therefore had to go through the entire prior approval process for his antidepressant meds all over again, and would have spent a year in hell if he hadn't been able to document the prior use of the less expensive meds. And the idea that we could replace that cardboard box with a smartphone or even a stick is very useful, and I think Blue Button has Blue Button and the policy work around making it clear that you cannot deny the patient that information has gone a long way towards making that possible. Where I get off the bus is with the notion that that is a replacement for any other form of interoperability. Because the cardboard box is interoperable because it's a person-readable document being read by a person. The notion that somehow the patient will solve these problems about half-ass coding and alternate coding systems and half-ass implementations of standards and on is naive. So I'm all for it as long as we don't think of it as a substitute for the hard work everybody's trying to do here. Thanks.
Thank you.
Yeah, and to my point, I think that the patient is the conduit. The validity and the value of the data and the connectivity of the data, I agree with you, it's a different issue.
The patient is the channel for the interoperability for, at a minimum, human.
Hi, I'm Lucy Johns. I want to say a couple of words about Direct Trust. Direct Trust is a nonprofit trade association. It is a membership organization. We have vendors, providers, PHRs, EHRs, individuals like myself. I'm a consumer. I've learned a lot of jargon that you all are so facile with, but I don't always understand what you say. But I just want to say a couple of things about what we're doing now. We mounted a directory pilot last year for our members. It's no longer a pilot, it's now operational. It has about over 400,000 endpoints in it. These are individuals, not institutions. This is individual based, and it's the direct addresses. And we are just debating whether to add fax numbers. So we are trying to envision a directory when fax doesn't exist anymore, but we may have to add fax numbers. We are also debating patient access to the directory. Now, our directory agreement keeps that information secure and private, and our HISPs, who are the curators of the information, required to keep the information accurate. So all that discussion about source of information, our health HISPs, health information service providers, who are our members, are the source of our information. They curate the information. It's supposed to be updated at least every 7 days, if I recall correctly. And the understanding is that only other providers, or clinicians we call them now, only other clinicians will have access. And we're now debating whether patients should have access. And the solution to that is our clinicians will be asked if that's okay, and there's going to be a cell in the certificate that says that's okay or not. We also have mounted a partnership for patients. This was just announced in May. ONC is very enthusiastic about it. And if you go to our website, the gentleman who asked about can't the patient be the source, we now have 4 buttons on our Partnership for Patient website where you can sign up to become the source of your data. And so those are 4 vendors making a system available to you to extract your data and send it where you want. So as the gentleman just said, 20 years ago, we all started thinking about this. I started thinking about it 10 years ago. I want to own my data. I'm a consumer. So the Direct Trust has a partnership for patients, which is attempting to meet that need in a variety of ways. So I encourage everybody to take a look at that. Thank you.
Thank you.
Well, thanks. That's an interesting comment. The one thing I'd add on to that, if I may, is I hope that any directories that are created with a Direct Trust or anybody else do adhere, though, to a standard, because we've always had directories. Every IT person can sit down in a database and do a SQL query and pull out, the entire patient census. What's missing in that, though, is interoperability and scalability. And so I think that the 3 things we've been talking about today, part of the goal is not only to publish that directory, which is what I think you're speaking to, but also to publish it in such a way that's interoperable with others, which means it can be used by others without special effort on their part. So I think that's the missing element I think we all are seeking to achieve now. So thank you.
I think everything and here's the consumer speaking, everything to do with interoperability starts with a group at a table. Mm-hmm. And their first question is, what do we want to do? And the second question for Direct Trust is it scalable? And so the directory, it's a flat file. It is scalable. Our HISPs do things with it that are extra services for their clients if they want to. Interoperability for the world, we hope, is coming. But we are just at the point, I just want to be clear, that this is accessible to our members. It is scalable within our Direct Trust framework, and interoperability with everybody else. We will see. Thank you.
Well, thank you. Appreciate that perspective. And I really hate disagreeing with anybody, so I'll just be very, 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 very low-key in my comments. But I would, as a software architect, assert that flat files are not scalable because they really, every time you have to import it, it's really a customization. Like, for example, if Texas has its own flat file format and Kaiser has their own, the VHA has their own, and Intermountain has their own, but what happens is you multiply it times 100,000 facilities across the country, each one having their own file format. Then you have to have 100,000 point-to-point connections, all different. And so the approach that I'm advocating is very different than that, of actually adhering to essentially a technical contract. And so all API is, we've been talking about APIs or applications programmer interface. So what that really is, it's actually a contract. It basically says, me as a data publisher, I'm going to adhere to this contract. I'm going to put the data in the format that we all, as an international healthcare IT community, have agreed to. And then you, as a user of that data, you also can, if you follow that contract, then you basically are guaranteed that the data comes from you, to you in a format that you also can consume. So anyway, I hate disagreeing with you. I also want to thank you because one of the things really, frankly, I think missing in healthcare IT is the consumer voice. In many cases, vendors are the only ones at the table, just because they're the only ones that fund or budget, staff to actually go to meetings every couple of months, to spend a week of their time actually doing standard stuff. And now, me as a consumer, because I'm actually work for 2 consumer companies, both nonprofit consumer companies, I actually built that into my before I got hired on, saying I want to be a standards person. I want to help contribute as a consumer, not as a vendor, to helping see these standards evolve. So I really do want to applaud you for being a consumer and being involved, and thank you.
Direct Trust is a platform for me as a consumer to always ask, how is this helping a consumer understand where their data are, what they should do with it, how they should share it, and so forth. About scalability, I can't really deal with you technically. All I can say is it was a place to start. It's making our members happy right now. It's going to go up to 1 million endpoints by the end of the summer. And if it's not scalable in some other frame, I'm sure we can talk about that. Thank you.
Well, thank you. Okay.
I'm going to try not to take us over the break time in a couple minutes. But I just wanted to share a little bit about something that we've done at Sutter Health. I think that the utility of provider directories is based, as you say, on the validity of the data that goes into them. And we at Sutter, when we crossed the MU2 bridge, I think like a lot of organizations realized that the data that we had in our system was not 100% accurate, that we suddenly started sending summary of care documents out via fax and other and snail mail to people, and they ended up going to the wrong places. So we had to quickly sort of backpedal and rethink our approach to that. And part of that is that we have stood up, now we're in the 2nd year of what we're calling a provider data integrity project, where we have literally budgeted millions of dollars to go out to all of the providers, both internal to our organization and outside of our organization with whom we share data, and basically validate their contact information and start to build that out so that when we send a fax or a piece of mail or a direct address or a direct message, that we feel that we are sending it to a valid recipient. And we've said that we're going to do this every 6 months for every provider with whom we communicate, and if they don't come back and validate, we're going to stop communicating with them. So we've stood up a call center, and we've hired all kinds of people, and they're literally, we had an email campaign, we had a fax campaign, we've now got a second round of a call center campaign, and this is a very big deal. I mean, it's a very big commitment that we've made to maintain the privacy of data that's going out of our systems. As we get updated data on these people, whether they're our internal people or partners, we are then updating the data that then we are sharing via direct. Via SureScripts, via Epic, so that we will always have what we believe to be the latest or a recently validated source of truth within our system. So I'm just curious, are you guys seeing this kind of activity on the part of other organizations? Is this going to become the standard of care? Or are we wasting millions of dollars trying to do something that nobody else is going to bother to do?
Well, I imagine my co-presenters also may have a thought on this, but I do know that one of the key federal agencies involved, the Health Exchange, basically has the same methodology at a national scale. And they're spending millions of dollars on outsourced contracts to a third party, or actually 2 third parties, to do the exact same quality assurance that you're describing. So the thing that really I would love to see us have a coalition or work together as a group of entities around is, why are we all paying for that? Isn't there a better way? Isn't there a way we could actually combine resources and have, say, a shared resource where we pay for maybe quality assurance once in a given region, rather than us all paying for that same function repeatedly? So yes, if you don't do that, the alternative is the data ages. I think the published metric I've seen several times is about 1% per month of the data becomes inaccurate.
I'm really glad that you talked a little bit about what you're doing. I think that there are 2 things that I want to make sure nobody in the room missed. Is it is important enough to you to have accurate information there that you're making this huge investment. And so provider directories are not a trivial, one of these little things that we'll just go ahead and do, but let's not worry too much about it. And second, that you're investing a huge amount of money in order to make sure that there's accurate data. And so anybody that thinks that this is a trivial thing to deal with data quality is okay, go talk to Stephen, because it's not. Smartest thing he did is make somebody else lead it for you. But not the smartest thing, a smart thing. But I have to agree with Eric. I can't imagine that all of the organizations are going to have the ability to make that kind of investment. And if they do, it seems like there's at least an opportunity for a lot of duplicative effort there. And I think that one of the things we'd have to do is figure out how we can coordinate that so that you have a part of that problem that you're investing in, but that you can reap the benefits of other people that are making similar investments as well. One of the things that we're really trying to do here in California is start to coordinate across all of the initiatives that are going on here. And that's not just the health information exchange initiatives, but really gathering together the stakeholders. And so we have a meeting coming up in August across the HIOs in the state, the large provider organizations in the state, the plans in the state, state government, the health insurance exchange, et cetera. You know, the other big stakeholders that care a lot about what's going on in provider directories, so that we can better align the initiatives that are going on there and look for synergies and opportunities to share information. And I think that only if we do that, it's just going to be a real tractable problem, because not everybody can make the investment that you're making, and you shouldn't have to carry that water forever.
Just a quick comment. So there are lots of open source tools that let you do back and forth SMS query or IVR and build platforms on that can help maybe cut down some of your operational costs. It might be worthwhile to look at those. I don't know if you've looked at those or not.
I just want to reemphasize one point I made earlier in passing about federation. That's why federation is such a huge value from a business perspective. Wouldn't it be great if we could leverage that investment that your leading edge organization has been making rather than duplicate it?
So I had two questions, which I'm just going to say, and you're not going to answer because we're going to adjourn real quick. One of them was, how do you manage temporary changes versus permanent changes? The difference between somebody being displaced during a tornado, hurricane, or whatever versus somebody moving their practice. And two, do we have standards for managing data provenance so that we can actually follow the trail of data as we go on? But I'm actually going to give Will the opportunity to have the last word here on this data issue if he wants, because I know you have some expertise in the validity of, or the length of time data has value. He'll pass. Okay.
Let me give you one.
So we are
give
going.
you a one-word answer.
Okay.
Yes.
Okay.
To both your questions.
Okay.
There is a standard that will do that.
So we're going to adjourn for break. Break will be shortened by about 5 minutes. We'll come back at about 3 o'clock, and we'll see you in a little bit. Thank you, gentlemen.